Alright guys, so we have discussed a lot of the pacemaker action potential. The most important element that we discuss and fully understand is the phase 4 slow diastolic depolarization. This chart here mentions that it is a spontaneous membrane depolarization as sodium conductance increases due to the funny current. And this kind of triggers the inward calcium movement. Let's further discuss how this actually happens. Now remember, we have very special and funny channels that are responsible for this slow diastolic depolarization. These channels sit in the membrane and they are bound by cyclic AMP on the intracellular side of the membrane. And these are our funny current channels. These are hyperpolarization activated cyclic nucleotide gated ion channels. So this makes a lot of sense. Hyperpolarization. When we hit around a negative voltage that is responsible for this opening of these channels, we can get an opening that allows sodium influx into the pacemaker cell. And remember, anytime we let in a positive ion, we start to shift the transmembrane voltage towards a more positive value. Now what if we didn't want just the baseline depolarization rate? Well, that is where cyclic AMP, our best friend, comes into play. Cyclic AMP can bind the intracellular domain of these funny channels, or funny receptors, on the pacemaker plasma membrane. Remember, they bind the intracellular domain because cyclic AMP is an intracellular signaling molecule. So if any situation we had the activation of the beta-adrenergic receptor, we would stimulate the G stimulatory subunit of the G protein complex, which would activate adenylyl cyclase, which will produce an increased amount of cyclic AMP. Now remember, this is due to some sort of beta-adrenergic stimulation where we would like an increased heart rate. So an increased amount of available cyclic AMP will bind these intracellular domains that bind cyclic nucleotides. So these funny channels respond to beta-adrenergic signaling by increasing in the frequency in which they open or slowly depolarize in diastole, because cyclic AMP will bind the intracellular domain of the transmembrane channel, allowing more sodium to flow in. The influx of sodium increases the transmembrane potential towards a more positive value, which will trigger the opening of calcium channels. The calcium channels that we discussed that are actually being activated in this last little segment of phase 4 are T or transient type calcium channels. The channels that dominate the phase 0, do not get them confused. These are L type or long acting calcium channels. So in a quick review, the funny current that is responsible for the slow diastolic depolarization that dominates phase 4 is initially determined by the transmembrane potential, because when a cell is repolarizing, it is restoring its negative transmembrane potential. This restoration of negative transmembrane potential actually activates these funny sodium currents, allowing an increase in intracellular sodium, which shifts our transmembrane potential towards a more positive value. This activates the T or transient type calcium channels to open, further increasing the shift of the transmembrane potential towards a more positive value, eventually causing the activation of the L type or long-acting voltage-gated calcium channels that is responsible for the phase 0. The T transient and the L long-acting are responsible for two different phases, but the transient type actually triggers the activation of the L or long-acting type that dominates the phase 0 upstroke. Excellent. Alright guys, let's keep on going. Alright, let's hit it off with the SA node, because we just discussed the pacemaker potential. SA node is sitting here. Remember, the cells here depolarize faster than all the pacemaker cells in the rest of the specialized conduction system. They set the intrinsic heart rate, because if one cell depolarizes first, the gap junction it shares with its neighbor will automatically follow suit. This impulse spreads throughout the atria and is represented as the P wave. As the atria depolarize, the potential falls until the whole atrial muscle is depolarized, and the potential difference ceases to exist. So we get a little peak, and now we're back to baseline. Thus, the recording will be at baseline or zero potential. Remember, these are relative potentials, so there's one negative electrode here and a positive electrode here. It only measures the potential change in between these two electrodes. This is why depolarization has a crescendo and then a decrescendo on the electrocardiogram. After the depolarization has spread through the atria, it will then hit the atrioventricular node in the center of the diagram. Why does it not spread directly into the ventricles from the atria? Well, there are fibrous rings surrounding the atrioventricular canals. These fibrous rings are there for a reason. Do you think that these collagenous structures allow conduction of current through them? Of course not. So how does the electrical impulse continue? There's actually one single opening where the atrioventricular node sits, and that is right here where we just circled with our pen. The AV node conducts the slowest velocity because its phase zero upstroke is mediated mostly by calcium channels, compared to the myocytes that are directly around it that are dependent on the fast sodium channels further upstroke. If the AV node is a pacemaker, then why doesn't it set the intrinsic heart rate? The AV node depolarizes at an intrinsic rate of 40 beats per minute, which is considerably lower than the 60 that the SA node sets. The depolarization triggered by the SA node will govern when the AV node is triggered, instead of the AV node's own depolarization rate determining the upstroke for the baseline depolarization rate of the heart. The AV node is a backup mechanism, because if the SA node fails due to ischemia, because a thrombus blocked its blood supply, the what artery, the right coronary artery, particularly the SA nodal branch, then you need to be able to continue depolarization of the heart. But instead, the AV node will set the pace. So knock out that SA node, and you can still get saved by the AV node. Alright, great. The second fastest conduction occurs through the atria, immediately followed by the ventricles. Where does the impulse go after it finally makes it through the slow AV node? Well, from the SA node, through the atria, through the AV node, you now enter the bundle of His, which is listed as the His bundle on your diagram, sometimes called the common bundle. I really would like the name common bundle to stick in your head, because it is the common bundle before you branch into the left and right bundle branch. Remember, these bundle branches eventually give off further specialized conductive tissue. So the bundle of His is just like the trunk of the tree that eventually gives off the branches, the right and left bundle branches. Here's your left, and here's your right. Now, these bundle branches, left and right, eventually give off further specialized conductive tissue. What are these called? The Purkinje fibers. What is special about these other than the fact that they are named after some random bohemian scientist? They have the highest concentration of fast sodium channels in the heart. Do you remember how we said that the number of fast sodium channels is directly responsible for the velocity of the upstroke phase zero in cells? It is certainly not a coincidence that the fastest conducing cells in the heart, the Purkinje fibers, have the highest concentration and number of these fast sodium channels. You have a bunch of channels that conduct sodium very quickly across the membrane, which means you have the fastest conductance in the heart. All cells of the specialized conduction system, from the AV node to the Purkinje fibers, have the ability to spontaneously depolarize. This does not include atrial and ventricular myocytes, unless you are in conditions of ischemia. Again, the Purkinje fibers can spontaneously depolarize at a rate of approximately 20 beats per minute only and only if the SA and the AV node are dead. This spontaneity is inhibited by the much faster depolarization that travels to them that originated from the SA node. So I'm kind of giving you some confusing information, right? How can the Purkinje fibers act as pacemaker cells, but also be the fastest conductors in the heart? Well, the key is that the transmembrane potential of the Purkinje fibers sits around negative 80 millivolts. So there is no inactivation of the sodium channels that are so highly populating these myofibrils. The only situation in which the Purkinje fibers would take over is if you lost the cells of the specialized conduction system above it, particularly the SA and the AV node. One important fact to recognize here is that the EKG is mainly a reflection of the electrical activity of the myocardial cells with an insignificant component of the electrical activity from pacemakers and the specialized conducting system. Remember, myocardial cells comprise most of the mass of the heart, and the total sum of all the electrical vectors is what's read by the ECG. So things such as the PR interval, which reflects the conduction delay through the AV node, does not create a large enough mean or total summation electrical vector to be detected by the electrodes. The only part that is denoted as red is the actual P wave in this segment or interval, because it's from the atrial myocytes, where there's a bunch of atrial myocytes and a large mean electrical vector. So, let's discuss the other intervals and segments on the ECG diagram. The QT interval is simply the time between the start of the Q wave to the end of the T wave. This interval includes the QRS complex, which represents ventricular myocyte depolarization, and the T wave that represents the ventricular repolarization. So what's the purpose of knowing the QT interval? Well, since it is the time required for the ventricle to contract and then relax, it is essentially telling you how much time the heart is spending in systole and diastole. This is important clinically because you can examine it to determine the patient's risk for developing an arrhythmia. I know what you're thinking. Is that all you're going to tell me about the QT interval when I've heard things like QT prolongation may lead to torsades? Or are you just going to tell me we will discuss this later in the pharmacology chapter? Absolutely not. We have to know the normal physiology and fundamentals before we can understand how and when things go wrong. Remember back to phase 3 of our ventricular myocyte potential. Phase 3 was the repolarization dominated by potassium efflux, which we call the IKR current. Now consider the plateau phase 2, that is countered by an efflux of potassium that occurs just before phase 3 repolarization starts. The plateau is there to provide sufficient time for calcium to enter via the voltage-gated calcium channels and open the gates on the sarcoplasmic reticulum, which is our calcium-induced calcium release. The plateau also keeps sodium channels inactivated during the refractory period to prevent the start of new depolarizations. Remember, those fast sodium channels will be reactivated if that calcium wasn't flowing in because we're losing potassium, and therefore we would hit that negative 60 that is necessary for those fast sodium channels to be reactivated. So what would happen if I prolong the action potential by giving you some drug like haloperidol? So I give you haloperidol because you're psychotic or you're in the middle of a manic episode, and I give it to you because you need it. Then I check an EKG on you. Your electrocardiogram will say that you have a prolonged QT, or to be more correct, a corrected QT interval, which would be a increased QTC. And that just corrects the heart rate. Don't even worry about that. Just remember, certain drugs like haloperidol can increase your QT interval. The voltage-dependent calcium currents have sufficient time to recover, and you can actually cause another depolarization before the cell has fully repolarized. And that is the basis of early and after depolarizations and delayed after depolarizations. These are termed early after depolarizations because we are creating new depolarizations immediately after just completing one without completing our repolarization phase all the way. If this concept isn't that clear now, do not worry. I'm going to talk about it more in just a second when we hit torsade de points. Just try to remember that if you prolong the action potential of a ventricular myocyte, by stretching out this phase 3, as you can see here, our phase 3 stretched out, some of those calcium channels recovered and were shut off, we hit our negative 60, and those fast sodium channels are ready to depolarize again. Because the fast sodium channels are ready to depolarize again, and so are the calcium channels, we set off another set of depolarizations. Basically, remember this. If you prolong the action potential by stretching out phase 3, the slope of the phase 3 will be more slanted due to the increased time interval. So because I prolonged the QT interval with haloperidol, which blocks those potassium channels, therefore stretching out the repolarization phase, we now have some fast sodium channels and calcium channels ready to reopen and fire another impulse, while other parts of the myocardium are not going to respond at all because they're still inactivated. So that means we can have one segment of our ventricle ready to fire again, and then this segment of the ventricle not ready to fire again. Sounds like a pretty bad situation, right? Could this or unsynchronization of inactivated and then also restored, ready to fire fast sodium and calcium channels possibly lead to a situation in which we have depolarizations in some myocytes while others in the same ventricle are not going to respond because they aren't ready to depolarize again? You bet. You can depolarize these, and then you'll have a depolarization current swinging around, and then eventually these will be ready to depolarize, and they'll depolarize. And then these will be repolarizing. The ventricle will continue to depolarize, and then by the time this gets back around, the segment will be ready to depolarize again. And now you have a reentrant circuit, and that's really, really bad. This is the basis of some arrhythmias. So would you say that these ventricular myocytes would be contracting out of rhythm if this were to happen? Absolutely. Now what does this sound like to you? This is the basis of how arrhythmias start, particularly torsade de pointe.